Cardiothoracic Surgery Part 2, or maybe the last part. Adult Respiratory Distress Syndrome, ARDS or shock lung. Etiology: severe sepsis, major trauma, severe acute pancreatitis, major burns, severe shock from any cause, especially if requiring large volumes of IV fluids, particularly in septic shock, lung injury due to trauma, inhalation of fumes, or aspiration of gastric contents. Pathology: macroscopic picture and microscopic picture. Macroscopic picture: great increase in lung weight, tracheal hemorrhage on epithelial surfaces. Microscopic picture: interstitial edema and hemorrhage, alveolar edema, perialveolar hemorrhage, intravascular fat globules, and fibrin plugs. Pathogenesis: activation of platelets, neutrophils, and macrophages, leads to release of oxygen-free radicals, causing endothelial damage, edema of lung tissue, increased capillary permeability, leading to movement of neutrophils and RBCs to the inside of alveoli. Defects occurring in three aspects of the respiratory process: defective ventilation, defective perfusion, and defective diffusion. Defective ventilation: the loss of surfactant reduces lung compliance and expansion. Alveolar edema: presence of fluid in alveoli prevents air from reaching the gas exchange surface. Defective perfusion: lung perfusion is affected if the cause of ARDS is shock. ARDS, acute respiratory distress syndrome again. Deoxygenated blood is shunted directly from some of the arterioles to the venular sites through opening of the AV shunts. Defective diffusion: the distance between alveolus and the capillary, known as alveolo-capillary membrane, is sickened because of the interstitial pulmonary edema. Oxygen and carbon dioxide find difficulty in crossing this sickened membrane. Clinical progress: initial state of shock, phase of hemodynamic equilibrium, phase of clinical respiratory distress. Initial state of shock: we have lactic acidosis and hyperventilation with low pressure of carbon dioxide inside the arteries. Phase of hemodynamic equilibrium lasts several days. The patient may appear well and recovering with a normal chest X-ray, but the oxygen tension is invariably low. Phase of clinical respiratory distress, followed by respiratory failure with confusion and occasional petechial rash. Rising tension of carbon dioxide and falling pressure of oxygen occurs despite oxygen supplement. Chest X-ray reveals bilateral pulmonary infiltrations. Treatment: the patient should be admitted to ICU. Respiratory support: in stage of respiratory distress, an oxygen mask is enough to improve arterial blood oxygen, and in stage of respiratory failure indicated by oxygen pressure less than 60 mm mercury, endotracheal intubation and mechanical ventilation are required. Treatment of the cause as correction of shock and eradication of sepsis. Postoperative hypoxia. Common causes: pulmonary aspiration, pulmonary embolism, failure to breathe deeply and cough during anesthesia recovery, airway blockage by secretions leading to alveolar collapse, hypoventilation due to pain of upper abdominal or thoracoabdominal incisions, opiates overdose, anesthetics, or prolonged recumbency. Clinical picture: restlessness, anxiety, confusion, tachypnea, tachycardia, dysarrhythmia, hypotension, and finally central cyanosis. Investigations: pulse oximetry, probe attached to one finger showing oxygen saturation. It's normally from 95 to 100%. Arterial blood gases: increased carbon dioxide tension denotes ventilation failure, and decreased oxygen denotes failure of any of the three components of respiration. Chest X-ray revealing underlying cause such as collapse or pneumothorax. Treatment of postoperative hypoxia: treat the specific cause, and if the respiratory failure occurs, mechanical ventilation is a choice. Mediastinal tumors. Pathology: tumors of the anterior and superior mediastinum include retrosternal goiter, thymic tumors, dermoid cysts, and teratomas. Tumors of the posterior mediastinum may be cysts of congenital origin such as bronchogenic, gastrogenic, and lymphatic cysts, lymphadenopathy of secondary deposits, TB, lymphoma, or leukemia, solid tumors of connective tissue or neurogenic origin such as neurofibroma, ganglioneuroma, and lipoma. Clinical picture: mediastinal syndrome. Dyspnea due to pressure on the air passages or encroachment on the intrathoracic space. Dysphagia from compression of the esophagus, edema, cyanosis, and dilated veins in head, neck, and upper limbs from obstruction of the superior vena cava. Hoarseness of voice and brassy cough due to involvement of recurrent laryngeal nerve. Hiccough and diaphragmatic paralysis from phrenic nerve involvement. Arrhythmias and ECG changes, EGG changes. No, it's ECG, it's a mistake. If there is pericardium invasion. Diagnosis: plain X-ray, opaque shadow in the mediastinum. Screening reveals the expansile pulsation of an aortic aneurysm or movement of retrosternal goiter during swallowing. CT scan localizes the site and origin of the tumor. Bronchoscopy to exclude bronchogenic tumors. Mediastinoscopy to take biopsy. Treatment: radiotherapy for enlarged malignant lymph nodes and malignant tumors, and may be supplemented with chemotherapy. Excision for cysts and simple tumors. Thymic tumors, incidence, rare. It includes thymoma, epithelioma, lymphomas, teratoma, and lymphangioma. Presentation: may be asymptomatic and discovered accidentally on X-ray examination. May present with features of myasthenia gravis or features of mediastinal syndrome. Treatment: radiotherapy followed by removal through a sternum splitting incision. Cardiac operations: preoperative diagnostic procedures, ECG, chest X-ray, thallium isotope, echocardiography, and finally cardiac catheter. ECG: resting, rhythm, conduction abnormalities, chamber hypertrophy, established ischemic changes, and old myocardial infarction, while exercise ECG shows exercise-induced ischemic changes. Chest X-ray shows cardiac enlargement and valve calcification. Thallium isotope scan, low isotope uptake indicates impaired myocardial perfusion. Echocardiography shows myocardial contractility, valve stenosis, or regurgitation, and septal defects. Cardiac catheter shows chamber pressures, assessment of left and right ventricular functions, and assessment of valve diseases, angiography, coronary artery anatomy, oxygen saturation, intracardiac shunts, cardiac output, cardiac function, and pulmonary vascular resistance. Left heart catheterization and coronary angiography are done by inserting a fine catheter into brachial and femoral artery with threading it up to the aorta. Similarly, right heart catheterization is performed through a peripheral vein. Operative procedure: extracorporeal circulation, the pump, and then we have the cardiac surgery complications. The extracorporeal circulation, the pump. Most cardiac operations are performed under direct vision in a bloodless field within the chambers of the heart or great vessels. A median sternotomy is used. The venous inflow to the heart is diverted through an artificial heart-lung machine. Extracorporeal circulation, which consists of pleural pumps, propel blood to and from the heart, oxygenator, supplying oxygen and removing carbon dioxide, heat exchanger, which controls blood temperature. The machine is filled with fresh heparinized blood. Venous blood is collected via cannulae and inserted into the superior and inferior vena cava. Venous blood is pumped through oxygenator and heat exchanger and returned as arterial blood by a cannula into femoral artery or aorta. Cardiac surgery complications: complications of extracorporeal circulation, hemolysis, cerebral ischemia, whether severe up to infarction or minimal, transient, postoperative psychological or memory disturbances, activation of cytokines which induce SIRS, usually minor but in rare cases may cause coagulopathy and renal failure. Low cardiac output, arrhythmias, pulmonary infection, mortality from 2% for routine straightforward procedure to more than 50% for complex emergency procedures. During extracorporeal circulation, the heart is not perfused. The myocardium is usually preserved by a combination of cardioplegia and systemic hypothermia. Systemic hypothermia down to 32 degrees Celsius reduces myocardial need for oxygen. Cardioplegia: the heart is induced to stop pulsations by infusing cardioplegic solution in the coronary arteries. It has high potassium content, minimizing myocardial oxygen requirements and allowing the surgeon to operate at comfort on non-beating heart. Cardiac arrest. Definition: cessation of effective cardiac output as a result of ventricular asystole, ventricular tachycardia, or ventricular fibrillation. The end result is sudden cardiac death. The common causes of cardiac arrests are 5 H's: hypovolemia, hypoxia, hyperkalemia, hydrogen ion excess, and finally hypothermia again, hypovolemia, hypoxia, hyperkalemia, hydrogen ion excess, and hypothermia, with 5 T's. Here, I'm not talking about the teeth. 5T, thrombosis, coronary or pulmonary, tension pneumothorax, cardiac tamponade, toxic orders, and trauma. Etiology of cardiac arrest, we have sudden severe reduction of venous return to the heart or severe depression of the myocardial function. Sudden severe reduction of venous return to the heart, we have three causes: sudden severe hemorrhage, severe peripheral vasodilation may occur after spinal anaphenia, and failure of cardiac filling due to pericardial tamponade, massive pulmonary embolism, or tension pneumothorax. Severe depression of the myocardial function, hypoxia, hypercapnia, massive myocardial infarction, irritating drugs such as epinephrine, hypothermia, acidosis and hyperkalemia, severe traumatic myocardial contusions. Types. According to the ECG findings, we have shockable rhythm and non-shockable rhythm. The shockable rhythm, ventricular tachycardia or fibrillation. The non-shockable, cardiac asystole, pulseless electrical activity. There is ECG rhythm compatible with a pulse, but the pulse is absent. Diagnosis. The cardinal signs are absent carotid pulse, absent or grasping respiration, look, listen, feel for air, dilated pupils, and under anesthesia, ECG monitoring of the arrest and sudden cessation of blood. Those are the main features. Management. The brain can only tolerate 3 minutes of complete circulatory arrest, and unless circulation is restored within this period, death or permanent neurological damage if the patient survives. Management is started immediately and consists of 3 phases. Pre-hospital management, CPR, external CPR by closed cardiac massage, and direct mouth-to-mouth breathing. The aim is not to restart the heart, but to provide an artificial circulation and artificial ventilation until appropriate facilities are available. Technique. The patient is laid flat on a firm surface and legs are raised to increase venous return. The person who performs external cardiac massage should press lower half of sternum by heel of the both hands. The elbow should be straight and chest is compressed 4 cm at rate of 100 compression per minute. A second person performs mouth-to-mouth breathing. The head is tilted back with one hand to ensure a clear airway, and the nostrils are closed with the other hand while the mouth is applied to patient's mouth to fill his lungs with expired air at a rate of 10 to 15 times per minute. Use of special tube and bag is preferable to avoid cross-infection. The efficiency of ventilation and massage must be monitored by observing chest expansion and palpating femoral pulse. Patient should then be transferred to hospital as soon as possible, with direct mouth-to-mouth breathing and cardiac massage continued until endotracheal intubation and medical treatment are available. Hospital management aim: restore normal cardiac rhythm, and endotracheal tube is passed and lungs are ventilated with oxygen. Venous cannula is inserted and suitable infusions are given. ECG monitoring is applied to differentiate cardiac asystole from ventricular fibrillation or tachycardia. Further management depends on ECG diagnosis. Cardiac arrest, we have cardiac asystole and ventricular fibrillation or tachycardia. For the ventricular fibrillation or tachycardia, we have DC shock. PCR should continue between steps of management. For the cardiac asystole, continue cardiac massage, adrenaline 1 mg IV or intracardiac with calcium chloride IV. Then we have 2 results, whether normal rhythm or ventricular fibrillation, and if ventricular fibrillation, we perform DC shock with PCR continued between the steps of management. Subsequent treatment in the ICU, measures are taken to prevent and to treat the re-arrest. Blood pressure kept more than 90 mm mercury by vasopressors and transfusion. If chest was opened, it's left open for half an hour in case re-arrest. Cardiac stimulants such as epinephrine, calcium chloride, digitalis may be administered as needed. Hypothermia and dehydration therapy with mannitol or concentrated glucose are induced if return of consciousness is delayed. Infusions of sodium bicarbonate solution are given to correct the metabolic acidosis produced by anoxia and blood transfusion. Hyperkalemia is often present and should be treated with calcium chloride or glucose and insulin. Anuria and renal damage should be anticipated and prevented. The cause of cardiac arrest must be investigated and treated. The stethoscope has no place in diagnosis of cardiac arrest. Once suspected and the carotid pulse is not palpable, start resuscitation immediately. Open cardiac massage. Indications: rarely if the chest is already opened and during a chest operation, or if closed massage has been unsuccessful. Technique: the chest is opened through the left fifth intercostal space and the pericardium is widely open to permit bimanual massage with one hand above and the other below the ventricular mass. Rate 60 to 80 per minute. Duration until the cardiac tone returns and heart becomes smaller, firmer, and pinker. Key points on management of cardiac arrest: CPR should continue between steps of management. If there is doubt whether the rhythm is asystole or fine ventricular fibrillation, don't attempt defibrillation. Instead, continue good quality CPR, which may improve the amplitude and frequency of ventricular fibrillation and improve the chance of subsequent successful defibrillation. Principles for surgeries on congenital heart diseases. Timing of the surgery: early after diagnosis, particularly for cyanotic heart diseases, to prevent development of irreversible lung changes which lead to pulmonary hypertension. Patent ductus arteriosus. Treatment: surgical closure. Timing: best between the ages of 3 to 5 years. Operation: through posterolateral thoracotomy. The ductus is exposed, ligated, using non-absorbable material, and there is no need for cardiopulmonary bypass. Coarctation of aorta, one of the surgically correctable hypertension. Timing: between the age of 5 to 15 years. Treatment: excision of stenosed part and end-to-end anastomosis if possible. Excision and grafting with dacron prothesis in lung constriction. Atrial and ventricular septal defects: the type of the patient, children or adults. Surgery requires cardiopulmonary bypass, but it's usually easy with low risk of complications. Repair according to the size of defect: small defects closed directly by sutures, while large defects closed by dacron grafts. Surgically correctable hypertension, renal diseases, renal artery stenosis, polycystic kidneys, coarctation of aorta, endocrine diseases, pheochromocytoma, Conn's syndrome, and Cushing's syndrome. Tetralogy of Fallot, consisting of 4 defects: stenosis of the pulmonary artery, intraventricular septal defect, dextroposition of the aorta, which overrides the septal defect and receives blood from both ventricles, hypertrophy of the right ventricle. Cyanosis is marked since birth, blue babies. Treatment: Blalock's operation, temporary palliative shunt. The subclavian artery is anastomosed to the pulmonary artery, and this improves blood flow to the lungs. Done in first year or 2 of life if cyanosis is severe enough to make total correction with cardiopulmonary bypass dangerous. Total correction, the definitive procedure. It requires cardiopulmonary bypass. The operation is usually advised before the school age. Principles of surgery for acquired valvular heart diseases. Mitral stenosis. Indications for surgery: progressive limitation of exercise tolerance, nocturnal dyspnea, atrial fibrillation, congestive heart failure, mitral valve opening less than 1 cm square as calculated by echocardiography. Optimal timing: between age 20 to 50 years. If younger than 20, reactivations of rheumatic disease may lead to recurrence, while if older than 50, myocardial ischemia, atherosclerosis, or emphysema. Methods: mitral valvotomy. Prerequisite: no associated incompetence and valve is not calcified. Method: by percutaneous balloon or by open heart surgery. Mitral valve replacement. Prerequisite: patients with mixed stenosis and incompetence and 4 calcified valves. Mitral incompetence: if the valve is not heavily distorted or calcified, valve repair is preferred than replacement. Narrow the valve annulus just enough to induce competence. If there is associated stenosis or heavily distorted and calcified, mitral valve replacement. Aortic valve disease. Treatment: valve replacement on cardiopulmonary bypass. Associated coronary artery disease is treated at the same time. Type of artificial valves: prosthetic valves, biprosthetic valves. The prosthetic valves have different designs as caged ball and tilting leaflets. Turbulent flow through these valves produce thrombosis, and patients take anticoagulants for life. Bioprosthetic valves. Valve leaflets are porcine, bovine, or human from fresh cadavers. Valve is suspended on a prosthetic ring to allow it to be sewn, and the recipient doesn't need anticoagulation. The lifespan of such valves is shorter than the prosthetic valves, but anticoagulation avoidance make them preferred choice in the elderly. Complications of valve replacement, valve breakdown, complications of anticoagulants, particularly bleeding, valve infection similar to bacterial endocarditis of native valves, prosthetic valve thrombosis if anticoagulants are discontinued. Ischemic heart diseases, etiology, narrowing of the coronary arteries by atherosclerosis, pathology and diagnosis. The most common symptom, angina pictures, but the disease may end in coronary thrombosis with myocardial infarction, heart failure, or ventricular fibrillation and sudden death. Diagnosis by history, ECG, exercise tolerance tests. Coronary arteriography is necessary before surgical treatment to determine occlusion sites and patency of vessels beyond obstruction. In atherosclerosis, the basic lesion is segmental atheromatous plaque, often within the first 5 cm of the origin and of a coronary artery. Multiple areas of occlusion are common, and about 50% of patients with severe angina have involvement of all 3 major arteries: anterior, descending, circumflex, and right coronary. Treatment, medical, moderation of activity, controlling risk factors, and medications. Controlling risk factors by prohibition of smoking and controlling diabetes, hypertension, and hyperlipidemia. Medications, coronary vasodilators, nitrates, beta blockers, and calcium channel blockers. And then we have the coronary revascularization. Indications, severe ischemia despite adequate conservative treatment. Methods, percutaneous transluminal coronary angioplasty, PTCA, or coronary artery bypass graft, CABG, CABG. PTCA, or percutaneous transluminal coronary angioplasty. Indications, for short arterial narrowing. Technique, insertion of a balloon catheter inside stenosed artery. The balloon is inflated to dilate the artery, and then the dilated artery is usually supported by a stent to keep it open. Coronary artery bypass graft. Indications, coronary arteries, those are not suitable for PTCA, stenosis of main stem of the left coronary artery, 3-vessel disease, particularly in diabetics. Surgery for complications of infarction include mitral valve reflux due to rupture of papillary muscle, ventricular septal defect due to damage of the septum, and aneurysm of left ventricle due to its weakness. Operative correction of these complications is commonly associated with coronary bypass, and the mortality is high. Technique, open cardiac operation using extracorporeal circulation and cardioplegia. Coronary bypass can be done by whether reversed saphenous vein grafts, internal mammary artery, or combination of both types, with recently the radial artery is used as a vascular graft. Reversed saphenous vein grafts anastomose proximally to ascending aorta and distally to the diseased coronary artery beyond the stenosis. The internal mammary artery employed as a pedicle graft when its left is attached to the subclavian artery proximally and to the diagnosed coronary artery distal to the stenosis. It has better 5 and 10-year patency rates than the saphenous vein grafts. A combination of both types is usually employed. The left internal mammary artery is used for a vessel at the front of the heart, and vein grafts are used to bridge other occlusions. Recently, the radial artery is used as a vascular graft. Results of coronary artery bypass graft: angina relieved completely in 70% of cases and improved in the remainder. Angina recurs with frequency of about 10% per year, and it carries mortality rate of 2 to 3% and 1 to 2% risk of stroke. High risk factors for morbidity or mortality for coronary artery bypass graft surgery: advanced age, older than 65 years, female sex, thinner, fragile coronaries, serious lesions affecting the main trunk or multiple coronaries, stenosis affecting the left main coronary artery, poor coronary distal runoff, dilated heart, left ventricular ejection fraction less than 30%, recent myocardial infarction before 6 weeks, associated valvular lesions, preoperatively uncontrolled systemic disease, thoracic aortic aneurysm. And before thoracic aortic aneurysm, we need to know about coronary anatomy. There are 2 main coronary arteries, right and left coronaries, origin both from the ascending aorta. Left coronary artery divides into LAD coronary, supplying the interior wall of the left ventricle and anterior 2/3 of the interventricular septum, circumflex coronary, supplying the posterior and lateral walls of the left ventricle. The right coronary artery supplies right atrium and right ventricle through the marginal branch. The right coronary artery, the left anterior descending artery, and the circumflex arteries, each considered to be a vessel system. Disease of any one of them or its branches is termed one vessel disease. Thoracic aortic aneurysm, etiology, atherosclerosis, the commonest cause, trauma, Marfan syndrome, syphilitic aneurysm, which is the rarest cause, presentation, mediastinal syndrome, it compresses superior vena cava, trachea, esophagus, and recurrent laryngeal nerve. It may also erode the vertebrae. Investigations, CT and MRI. Treatment, surgical excision of the diseased segment and interposing a synthetic graft. 3 branches of the arch are implanted in the graft. Complications of the surgery, paraplegia due to interruption of the blood supply of the spinal cord. Aneurysmal dilatation may affect the aortic arch, the descending thoracic aorta, or may extend into the abdomen, forming a thoraco-abdominal aortic aneurysm. Aortic dissection, predisposing factors, atherosclerosis and hypertension. Pathology, intimal tear, the blood dissects its way in the media, false lumen, leading to rupture inside the true lumen or to the outside, leading to fatal hemorrhage. As blood dissects its way distally, it occludes ostia of the aortic branches, leading to ischemia. Of particular importance are the coronaries, the renal, and mesenteric arteries. Types, we have A and B. A is the more serious type. Dissection starts in the ascending aorta, leading to aortic incontinence, coronary artery occlusion, and fatal cardiac tamponade, while type B, the dissection starts distal to the arch. Myocardial infarction may also be present in type A, and diagnosis is not easy. Clinical picture, severe chest pain which radiates to the interscapular region, and it's commonly misdiagnosed as acute myocardial infarction. Investigations, CT, ECG, aortography, echocardiography, particularly the transesophageal. Treatment, for type A, urgent surgery for the placement of a synthetic graft at the root, replacement of aortic valve, and reimplantation of coronaries in the graft. Type B, antihypertensive treatment. Elective surgery may be needed in chronic extension of the dissection. And then we have finally the bronchoscopy indications, diagnostic, in bronchogenic carcinoma, therapeutic, removal of a foreign body, dilatation of airway structure, bronchial suction of secretions in cases of resistant atelectasis, and finally, laser ablation of obstructing bronchogenic carcinoma. Types, we have rigid and fiber-optic bronchoscopy. The rigid bronchoscopy requires general anesthesia, better for removal of foreign bodies and secretion, better for biopsies and controlling bleeding. Fiber-optic bronchoscopy, it doesn't necessitate general anesthesia, more convenient, and it allows wider visibility. And this concludes the cardiothoracic surgery.